Good afternoon, everybody, and welcome to this the webinar about the first results of our research consortium, RIVER EU, and it's about reducing inequalities in vaccine uptake in underserved communities in the European region. I would first like to thank UVA, the European Public Health Association, for organizing this fantastic Public Health Week, in which we have the opportunity to present our first results. I would also like to thank EuroHealthNet to organizing this webinar. And I'm very glad that all the researchers from our consortium, from the different countries, will share their first results of the barriers that underserved communities will or are experiencing in the vaccine uptake. So we have a very tight schedule. That means that the presenters have more or less 5 or 6 minutes to present their results. And I am chairing this session, so I will indicate if your time is almost finished. When the audience has some questions, please use the chat function to raise your questions, and we have, I hope, enough time in the question and answers round to address your questions. I would also welcome Michael Rigby, Professor Michael Rigby. Michael is the chair of the External Advisory Board of RIVER EU. And there we see Michael. Hello, good afternoon. And Michael will help us with answering the questions and also, well, wrap up this webinar at the end of the session. So I think I have addressed all. I would first like to give the floor to Daniela Filakovska-Bobakova, a very experienced researcher from Slovakia. And Daniela will present on the experiences of the Roma communities in Slovakia. Daniela, the floor is yours.
Thank you very much, Daniel, for this introduction. I am pleased to be here and introduce you to the situation in Slovakia. Next slide, please. So Roma are the largest and most disadvantaged ethnic minority in Europe, as well as in Slovakia. Out of approximately 440,000 Roma in Slovakia, more than half live in marginalized Roma communities. They often experience generational poverty, limited access to education, employment, housing, and various types of services, including healthcare. Marginalized Roma are also considered to be hard-to-reach population with low levels of trust towards non-Roma. Next slide, please. So we interviewed more than 50 people, marginalized mothers, daughters, and health professionals. Even we were focusing on the health system barriers to Hpv vaccination, we couldn't avoid barriers on the side of marginalized Roma. Most significant barriers seem to be low health literacy and low awareness. Regarding health system barriers, 4 main themes were identified as listed on the slide. Within the lack of information, we found that there is a lack of culturally and linguistically appropriate information. Also, lack of information provision from healthcare providers who do not inform their patients about HPV and do not offer HPV vaccination to them. And also there is a lot of unreliable and conflicted information on the internet. Regarding restricted access to healthcare providers, the most pressing issues concern lack of capacities and work overload in healthcare providers, but also distance and traffic connection between communities and healthcare facilities. Financial and organizational barriers concern limited coverage of vaccination expenses from health insurance, as the vaccine is fully covered only for 13 years old. Also, parents need to pick up prescribed vaccines in a pharmacy, and parental consent is needed. The last group of barriers emerged not only in connection to HPV vaccination, but also concerns problems in healthcare as such. Roma respondents often mentioned neglect of care, double standard practices, inappropriate behavior and communication, prejudices and racisms of healthcare providers. So healthcare providers are often convinced that the health system is built and is working for everybody because we have universal health insurance coverage, we have healthcare facilities, we have doctors, and they have their opening hours. So everything that the patient needs to do is to come and engage with it. And doctors often perceive Roma as those who are not able to do that. And in this point, many prejudices step forward. And they are not aware of the system being not responsive towards the specific needs of different people. Marginalized Roma, on the other hand, often perceive health system as unfriendly, and they have bad experiences with attitudes and behaviors of healthcare providers. They avoid healthcare also for other reasons, for example, because they feel ashamed to visit the doctor because of bad hygiene. So the way they are using healthcare system and vaccination services is quite different compared to the way majority population uses it. Nevertheless, HPV is not viewed as a priority by both marginalized Roma and health professionals. Health is often pretty low on the list of the priorities for people living in poverty who face discrimination in all aspects of life, struggle to feed their children, or do not have access to decent housing. So looking so far to the future, trying to avoid possible health risks in a context of their day-to-day life is unthinkable for them. Healthcare providers, on the other hand, struggle with their capacities with providing basic healthcare, such as treatment of sick children, mandatory checkups, or mandatory vaccinations for children from marginalized communities. Having around 3,000 children on their agenda, they do not have the capacity to go beyond what is necessary, and they simply do not offer HPV vaccination to the people. Next slide, please. So when it comes to building bridges between communities and healthcare, we are lucky enough to have existing health mediation program, which is running under the contributory organization of the Ministry of Health called Healthy Regions. Approximately 300 Roma health mediators in marginalized Roma communities are living and working on a daily basis directly in the communities, raising health awareness and helping people to overcome barriers to healthcare. Next slide, please. So we need to bring the topic of HPV and HPV vaccination into the communities by using existing network of Roma health mediators. We can train Roma health mediators to educate people in the topic of interest and provide them with culturally and linguistically appropriate printed materials, organize educational sessions with mothers in community centers and with adolescents at school. And these kind of measures are perceived as temporary compensatory measures, but we need to do the changes in healthcare system itself to make it more user-friendly. So firstly, we need to widen the age group for which the HPV vaccination is covered by health insurance to at least from 9 to 15 years and to simplify the way the vaccination is organized. We should consider maybe introducing compulsory vaccination against HPV, and we definitely need to increase the capacities of healthcare providers in the catchment areas of marginalized communities. Thank you for your attention.
Yes, you can hear me again, I hope. Yes. Okay, thank you, Daniela, for your very interesting presentation. The second presenter is Maria Ganczak, professor and head of the Department of Infectious Diseases of the University of Zielona Góra in Poland. And Maria will share the results regarding the Ukrainian migrant community in Poland. Maria, the floor is yours.
Maria, you're muted.
Good afternoon. Thank you, Daniela. I would like to give you a short explanation why we chose Ukrainian migrant community and why we chose HPV and MMR vaccinations. So since early 2013, there has been a rapid increase in the migration from Ukraine to Poland, and we estimate that there was about 1.25 million of them in our country. However, the current humanitarian crisis, which we are observing currently, has taken about 3.2 million people to us. So the situation is a little bit different. This previous Ukrainian migrant community consisted primarily of economic migrants of working age, and they were mainly at the early stages of migration. So they were working few months in our country, then returning to Ukraine to extend visas, and then coming back to Poland. The next slide, please. Regarding vaccination uptake in Ukraine, you may see that in 2020, only 82% of their children had been vaccinated against measles. The next slide, please. And regarding measles, we may see that in 2019, among 42 countries of the WHO European region, the majority of measles cases were reported in Ukraine. And on the right-hand side, you may see the increasing number of measles in Ukraine. The next slide, please. Regarding HPV vaccination uptake, there is no data coming from Ukraine. However, some studies show a disturbingly low uptake. The next slide, please. So just to wrap up, Ukrainian migrant community in Poland, this is the mobile community with low immunization rates, moving from a country from negative attitudes towards immunization and high measles incidence. The next slide, please. Regarding barriers and MMR vaccinations, when we look at migrants, there is the main language barrier, but also low health literacy and low awareness of vaccine preventable diseases. When we refer to health system barriers, there's a lack of information, insufficient coordination of health services in both countries, lack of universal vaccination reporting system, insufficient vaccination regulations in Poland, and in Ukraine, and unfortunately false immunization certificates. According to migrants, these can be obtained by bribing. Next slide, please. So you may see here a quote from one of our 50 Ukrainian migrants, which we interviewed through the focus groups discussions. Among my friends now, there are a lot of people who buy vaccination certificates, not only when it comes to COVID vaccinations, but also for kids. Next slide, please. So most Ukrainian migrants are distrustful of vaccines, and the commonly held view is that pharmaceutical companies promote specific vaccines to increase profits. Next slide, please. Regarding HPV vaccinations, barriers regarding migrants are almost the same when compared to MMR, but there are different health system barriers. There's a lack of information about HPV and cervical cancer because such information is not provided in school curriculum. HPV as a topic is not targeted there. And HPV is a non-mandatory vaccine, only partially refunded by the state. And so in Ukraine, there is no interest in such mandatory self-paid vaccines simply because they cannot afford such vaccines. Also, as mentioned previously, there is insufficient vaccination regulation in Poland, and there are difficulties in reaching Ukrainian parents, but also teenagers, so they are in a sort of gap and they are not covered. They are out of reach. What about, yes, you may refer to the next slide. What about building bridges on the community level? To train community leaders to educate migrants in vaccination-related issues, to provide them with translated versions of vaccination-related materials and other information in their own language. And certainly increase the role of the frontline healthcare workers in sufficient information delivery. Next slide, please. Regarding building bridges on national level, we should introduce legislative changes to increase access to vaccination for migrants, launch vaccination campaigns which specifically target migrants, offer website education in their own language, provide GP practices with extra staff and portable translators, and of course, last but not least, establish free of charge vaccination for HPV. Thank you for your attention.
Thank you, Maria, for your presentation. The third presenter is from Greece, and her name is Pania Karnaki. Pania is head of the Department of the European and International Research Project at Prolepsis. And well, she will share the barriers that the migrant population in Greece experience. Pania, the floor is yours.
Thank you, Daniela. Thank you, everyone, for attending this session. So for Greece, we are focusing on migrant and refugee children and adolescents. And the reason basically, as you all know, is that Greece has received very large numbers of migrants and refugees since 2014. Some of the numbers are found here from the UNHCR website. The peak was in 2015 when we received approximately 857,000 migrants. In the recent years, we have seen a decrease primarily because of COVID-19. But in 2019, for example, we had almost 60,000 migrants and refugees. Next slide, please. So in Greece, we conducted 4 focus groups with healthcare professionals, migrants, migrant girls and boys and mothers, and 23 personal interviews, again with health professionals, mothers, migrant girls and boys. Next slide, please. What we identified as barriers at the system level was a significant lack of political will to set standard operational procedures, SOPs, regarding the immunization of migrants, which would facilitate the work reception services need to do. SOPs would cover which vaccines need to be mandatory performed instead of performing vaccines that are available at any given moment. SOPs would also resolve issues such as lack of vaccine flow, lack of common data vaccination registries that would record vaccinations received either by public or NGO vaccination services. Vaccine hesitancy due to a lack of appropriate culturally sensitive vaccine-related information and limited opportunities to ask questions. As system-level barrier, we also identified a lack of health promotion initiatives addressing vaccination and benefits more broadly. Also, there is no fixed vaccination schedule when migrants enter the country and during their first stay in camps. Priority is given to vaccines that can cause outbreaks and epidemics, such as the MMR vaccine. We had other interesting findings as well, such as girls and mothers are more acceptable to vaccinations compared to unaccompanied minors, for example, who in our sample perceived vaccinations as something compulsory or mandatory, so they did not favor vaccinations very positively. We also realized that the role of NGOs is really important and that mothers have a pivotal role in vaccination. Next slide, please. Specifically concerning the MMR vaccination, most of the people who we spoke to are familiar with this vaccine, although they are not certain whether they have received it or not. Most children do receive the MMR vaccine upon arrival to the country, but MMR vaccination is very often unnecessarily repeated, and this is because of a communication break between the services. Next slide, please. Concerning HPV vaccination, what we found out and what also confirms findings from the literature review is that HPV vaccination is really unknown among our sample population. And when we spoke to health professionals, they confirmed that HPV vaccination among the migrant population is practically non-existent. Health professionals were only aware of a small NGO that conducted HPV vaccination opportunistically. There is a lack of relevant information and an absence of HPV vaccination in CAPs on the islands and also on the mainland. Next slide, please. So some of the solutions that we are looking at system level is, first of all, to ensure equal access to all vaccinations, irrelevant of legal status. Also to simplify the way vaccination is organized and involve and create synergies with NGOs, schools, and shelters. This is really important. To establish SOP, standard operational procedures, that would outline necessary vaccinations when entering the country. This would enable all relevant vaccinations to be performed, avoiding opportunistic vaccination only with available vaccines. Next slide. Also, it's very important to create vaccination registries to avoid unnecessary vaccinations and ensure booster shots. Communication campaigns in migrant languages, allowing for interaction, questions. We have received many questions, which shows that there are a lot of things that are unknown among this population. It's important in these communication campaigns to provide navigation guidance, to ensure cultural mediation, and to use safe spaces such as schools, especially for HPV vaccination. And finally, to target boys, especially unaccompanied minors. Thank you very much for your attention.
Thank you very much, Pania, for your presentation. Then I would like to give the floor to Janine de Zeeuw, and I have to share seats with you, I think, Janine. Janine is postdoc researcher at the Global Health Unit of the University Medical Center in Groningen, and she will share the barriers that female adolescents with Turkish or Moroccan migrant background experience in the Netherlands.
So thank you, Danielle. I hope you can all see and hear me. So thank you for joining this webinar. And as Danielle indicated, I will share with you our health system barriers as indicated by our community members and healthcare workers in the Netherlands. So in the Netherlands, we focus on the Turkish and Moroccan people living in the Netherlands. To give you a bit of background of our underserved population, in the Netherlands, about 400,000 people of Turkish origin and about 400,000 people with a Moroccan migration background are living. They mainly live in the larger or in large cities throughout the Netherlands. They mainly tend to belong to a group of people with lower socioeconomic status. And within our project, we focus on the first, second, and third generation. The next slide, please. So in the Netherlands, our national immunization program started with HPV vaccination since 2010. When a girl is turning 13 years of age, she is receiving an invitation letter for her HPV vaccination. And the vaccination itself is offered through mass vaccination sessions. However, from this year onwards, our program is changing. So the program is not only focusing on girls, but also on boys. And they will receive an invitation letter for their HPV vaccination in the year they turn 10 years. So that's currently changing in our program. So as I said, we're only focusing on HPV vaccination. And as you can see on the slide, if we look at the uptake and compare the uptake of HPV of the Turkish and Moroccan girls as compared to the national population, you see that the uptake is much lower as compared to the national HPV uptake. So what we did is we conducted interviews with community members, and we've organized focus group discussion with healthcare professionals. And on this slide, I share with you some preliminary results on the health system barriers that were identified within our research project. And an important barrier that we identified, as mentioned by community members, is the language barrier, for example, in the invitation letter, but also in communication with healthcare professionals. To give you an example, for some community members, it's difficult to read Dutch, while our invitation letter is in Dutch. Another important factor is the fact that HPV is being addressed as a sexually transmitted disease. And according to the community members, the girls only start to become sexually active after their marriage, so they don't see the necessity for an HPV vaccination. According to the community members, there's also a lack of knowledge concerning HPV, concerning HPV vaccination, and also on cervical cancer. But they are in need of more information, or more information that is tailored to their needs, or to their needs concerning their cultural background. There's a lack of trust mentioned concerning the vaccination. There's also lots of discussions about side effects of the vaccination. So that is also being mentioned in the focus group or in the interviews. Also, the fact that it's being offered through mass vaccination sessions might relate to the fact that it's not being aligned to how the underserved community would take the HPV vaccination. And also a lack of time and a lack of personnel has been mentioned in our study. Can you go to the next slide, please? Yes. So what we did in our project in order to build bridges with the community, because of course it is very important to have collaboration with members of the community. So we collaborated with a lot of organizations in the Netherlands that were already in close collaboration with the target population. What we also did, for example, through NGOs or through other organizations that were already collaborating with community members, is that we were able to organize information sessions on HPV vaccination, and on cervical cancer. And through these organizations, we were able to reach out to community members. And within these sessions, but also within our communication with the community members, we used material that is culturally aligned. For example, we also used simple language to overcome the language barrier. So apart from the health system barriers, we've also reviewed and discussed about evidence-based interventions that can be implemented to improve the HPV vaccination uptake. And of course, we will continue with our close collaboration with the community or representatives or key persons from the community. And there is promising approaches that might fit the health system barriers that were identified, and they're closely aligned to educational activities for the community members, for example, and using the existing networks and also education that is culturally aligned to the underserved community in the Netherlands. But also, for example, education for healthcare professionals on how communication with community members specifically on HPV vaccination can be improved. Thank you very much for your attention.
And here I am back again. Well, you have heard several examples of underserved communities and the health system barriers they experience. We also have included in River EU some countries and underserved communities that have a high vaccine uptake despite being a community that is deprived or discriminated or has a low socioeconomic status. And I am happy to let you know that we also want to share these results of one such an example of a high uptake in an well, normally underserved community. And these results will be presented by Jumana Essahadat. And Jumana is Research Associate at the Faculty of Medicine of the Bar Ilan University in Israel. Jumana, the floor is yours.
Good afternoon. Thank you, Danielle, for the introduction. As Danielle said, we heard from our partners about the different minority groups across Europe and the barriers that they face in getting vaccines. And today I will share with you a different story. It's the story of the Arab minority in Israel and how, despite being a disadvantaged population, they are actually an empowering example in terms of vaccination. So before we talk about vaccinations, it's important for me to give you a bit of a description about the target population that we are talking about so you can place things into context. The Arab minority in Israel is a very unique population group that comprises over 1.9 million citizens, and it makes up over 21% of the general population in Israel. Within the Arab community, there are several diverse cultural and religious groups. 82% are Muslims, 9% are Christians, and 9% are Druze. The Arab community, generally speaking, is a very young population with an average age of 22 years, and 43% of the population group is younger than 18 years of age. Households are relatively large, with an average of 4.6 members per household. As you can see in the map that we have here, half of the Arab Israeli community lives in the periphery, with over 70% living in the North and Triangle region. And the rest live in major mixed cities like Haifa, Jerusalem, and Tel Aviv. Only 52% of the Arab community participates in the labor force, and this is mainly due to the low participation of women in the employment market. However, most families do have at least one member who work in the healthcare system. Household income is a little over half of that of the Jewish Israeli community. The population group is very socioeconomically disadvantaged. 8 of Israel's 10 poorest cities are comprised of Arab citizens. And unfortunately, almost 50% of the Arab community lives below the poverty line. Next slide, please. So as you can see, the Arab minority in Israel is a socioeconomically disadvantaged minority population. But despite this, this community has a high vaccine uptake for childhood vaccinations, which makes it what we are calling an empowering example. If we look at the Arab community, 24% of Arab children are more likely to be vaccinated than the general Jewish population. There's a very high consent to HPV vaccines, over 98% versus 54% when comparing to the Jewish population. To better understand why this community has such high vaccination rates, despite being a disadvantaged minority, we have conducted in-depth interviews with teens, mothers, and soon we will start to collect data with the health professional staffs to understand what health system enablers make it easier for the community to get such vaccinations. Next slide, please. So as I said, we are still in the process of data collection, but I would like to present you with some preliminary results. Let's start with the interviews with Arab mothers. So far, we have conducted 12 in-depth interviews, and it is clear that there are health system enablers that makes vaccination easier for this community. First, mothers reported that the vaccination services are very accessible. Childhood vaccines are given in mother-child clinics, which are located within the neighborhoods and towns, and are often within walking distance or a short drive to the mothers. In terms of the HPV vaccine, this vaccine is given to children in the 8th grade in the school system. Vaccines are also included in the basket of health services, so they're provided at no extra cost to the mothers. From the interviews, it is clear that there was an extremely high level of trust among the mothers towards the healthcare system, as well as towards healthcare professionals. Almost all mothers shared that they didn't really think twice about giving their child vaccinations, and that if it was something that the professionals and doctors told them needed to be done, they just did it. In fact, with HPV, mothers reported that the school sends home an information sheet on the vaccine and tells the child to bring their vaccine card because they are getting vaccines next week, and they just send the cards and really ask no more questions. There's no dialogue or controversy among the parents or between the family members. It's just something that they believe needs to be done. Another issue that Arab mothers reported as an enabler to vaccination was that the healthcare nurses were usually Arab, which made them more comfortable because they understood the unique cultural and social characteristics of the population. They also indicated that a lot of the educational material that they received and the letters describing the vaccination were also translated into Arabic, which was very helpful. Interestingly, despite such high vaccination rates, mothers had very limited knowledge regarding vaccines. They knew it was a vaccination to prevent disease, but were not really aware of details or what it was preventing. Next slide, please. If we look more specifically at HPV vaccinations and look at some preliminary results from interviews with the Arab youth, we see that the youth are not part of the decision-making process. We interviewed thus far 6 in-depth interviews with teens who were 14 to 15 years old, all who indicated they received the HPV vaccination in school. The vaccination was presented to the child as something that needed to be done. They did not feel that they had any choice or decision to make. They were told that they were getting the vaccine and to bring in the vaccination record, and that was it. Everyone in the class received the vaccine. Again, like the mothers, they had a very limited knowledge regarding what the vaccine was, why it was being given. They simply knew that it was one of the vaccines that they had to get to prevent disease. However, interestingly, not one of the teens or the mothers were aware that it was associated to preventing cervical cancer, and they did not know how the virus was spread, and no one brought up the association as being associated with sexual transmitted infection. Next slide, please. So this, just to summarize, this research does provide some important insights into health system enablers that we see here with the Arab population in Israel regarding HPV and MMR vaccination. And we hope that such evidence can serve as a basis for interventions and guidance to improve vaccine uptake among other underserved minority communities in Europe. Next slide. Thank you for your attention.
Well, thank you, Jumana, for your nice presentations, and also to well, hear from you what is going well in your country, and hopefully learn for that from that for EU. Well, we have now enough room for questions and answers, and I would love to read the questions and in the chat function, but my screen is a little bit very small, so small that I cannot read it. So Hanneke, Hanneke Vervoort, also a very important person in River EU. Can you assist me in this?
Yes, I can read the questions, and the first one is from Sandra to Maria. What is the impact of the war and 3 million refugees in Poland at the moment? And does that is there a change of strategy by the Polish government or the WHO to avoid large outbreaks? So maybe Maria can elaborate a bit on that.
Yes, Stefano, thank you for this question, because it really shows how the approach to migrant vaccination differs when compared to before the war and after. Because for months, even years, we had been asking our authorities to at least provide our family physicians with some written materials or some websites which will enable them to provide more comprehensive care for Ukrainian migrants.
Maria, can I interrupt it? You have to keep your microphone somewhat, yes, because we hear your...
Thank you.
Yes.
Well, for months, even years, nothing had been done. But since the war started and since these refugees started coming to Poland in hundreds of thousands and even million, so now the first thing is that the government provided a short cut for them for getting IDs and health insurance, which is obviously the first step to be vaccinated. And the second thing is that there are many initiatives provided by medical organizations such as family physicians organization, etc. So they started to open some websites with some translators and some manuals, some menus, which enormously help especially first-line healthcare workers to communicate with migrants. And another initiative is that we may volunteer, me personally, I'm doing that, we may volunteer to consult these migrants for free, despite it depends on our specializations, but also infectious disease specialists do such or provide such services. So, but unfortunately, there is not much interest in vaccinations, I would say. There's much more interest for non-communicable diseases. For example, if a child was treated with some sort of treatment in Ukraine, and now there is a shortage of therapeutics, so in such cases, mothers just come to see physicians. But regarding even we are doing now heart transplants to Ukrainian children in Poland. But regarding vaccination, I would say it's a sort of disappointing that they don't put much interest in vaccinate their children at the moment.
Hanneke, do you want to read the next question?
Yeah, the next question is about the vaccine, the HPV vaccine for boys. As the Netherlands is implementing that, the question is, are more countries doing that? And I see in the chat also people already answering that the UK is doing that and Israel as well. But maybe it is good to refer to Michael. Would you be able to say something about this, or who do you want to have the question answered, Danielle?
Well, any of the speakers who wants to say something, I will invite. Daniela, Pania.
Well, in Greece, it is recommended for boys at this stage.
In Slovakia, the vaccine is fully covered for both boys and girls, but there is only this small opportunity window. It's a 1 year between 12 years and 1 day until 12 years and 363 days. Okay, so only 1 year, and then the vaccine must be covered by out-of-pocket payments.
So that is already one health system barriers regarding this kind of vaccination.
Yeah, maybe I see in the chat coming in that Alison indicates that Latvia has also introduced HPV vaccination for boys as well. And Italy and Belgium as well. So it seems that many countries are slowly starting the boy vaccination. Maybe go to another question. Alison indicated this one is for Jumana, that she's wondering if there are also policy-oriented solutions in the Arab-Israeli empowering example, which you can discuss. As she said that most of the enablers were grounded in cultural you presented, but is there also supportive legislation or policy that increases vaccination uptake?
Thank you, Alison, for the very important question. You know, the Ministry of Health has specific committees set up and is always working through the mother-child clinics to make sure that the information and education that's given to the Arab parents is culturally sensitive and culturally appropriate. In terms of policies, you know, the policies are very similar for the Arab community and the general Jewish community. And I don't know, other than, you know, the vaccination being free and at no extra cost, the policies, you know, are more towards focusing on making sure that the vaccine is available, the clinic hours are, you know, are open and accessible to the mothers. On the policy of giving the vaccine, the HPV vaccine in the schools has really, you know, helped increase the uptake of the HPV vaccination among the Arab teens. But, you know, like you said, most of the enablers that were raised by the mothers are surrounding cultural issues. And as a community, there is a lot of trust in health professionals and in the healthcare system, which is, it's very interesting because, you know, as we all know, there's not a lot of trust in the political system among the Arab minority. So, but in the case of, you know, healthcare, it's a different story.
Thank you, Jumana. Are there more questions in the chat, Hanneke?
Yes, we have one more from Sandra Mounier. Do you think that mandatory vaccination increases distrust in vaccines in migrant communities? So does the mandatory component cause distrust?
Would you like me to answer that? Or Daniela?
Yes, whatever. Please start, Pania.
Okay, so it depends on who you are talking to, because migrant communities are so diverse, at least in Greece. From our focus groups, we saw that among unaccompanied boys, there was indeed a lot of mistrust towards vaccinations. And what they told us is that they don't believe in vaccinations, and they definitely mistrust vaccinations. So there is a lot of work to be done with a specific group. On the other hand, mandatory vaccination has been considered as a positive measure, because many times migrants believe that if they will have the mandatory vaccinations, then it will facilitate them, it will help them to get to their final destination. So it can be used in a positive way. But as I said in the beginning, it really depends on who you are talking to.
Thank you. Daniela, do you want to add?
Yeah, well, regarding the Roma in Slovakia, we don't see them as migrants, because they are here already for centuries, so rather ethnic minority group. But especially for those that section of Roma population which is living in poverty, and that goes hand in hand with low levels of education, the mandatory vaccinations is seen as something what is necessary and good for their children. If it's not mandatory, then they perceive it as, well, not mandatory, it's probably not working that well, and then we don't need it. So they really have this simple kind of reasoning that they trust if it's mandatory, and if the healthcare provider will tell them that we need to vaccinate your child. But if it's not mandatory, then they avoid it at all.
Thank you, and that is very interesting. So you can see that it depends on the culture and the history maybe of a country. Hanneke, are there more questions? Maybe one final question?
No questions in the chat anymore. So maybe.
Well, then I give Michael Rigby somewhat more space to make a conclusion. Michael, are you ready to give your reflection or conclusion on the webinar?
Thank you, Daniela. Yes, I am. I'm somewhat overwhelmed by the richness of the presentations and the variety of good scientific evidence we're receiving. I think I'm also becoming increasingly overwhelmed at the variety and the dynamic change of what we've called marginalized or underserved communities, not least because of the very sad situation in Ukraine, but with other groups that are moving in a hurry and settling in a hurry and are difficult to reach for those reasons. I have been making a few notes as I listen to the presentations, and I start off with the thought that the title of the session was actually very far-sighted, and it was building bridges. And I think that is a key element that is so important in all the scenarios we've heard, to making sure that we work to bridge, to link, to share, to communicate between for lack of better terms, the majority and the minority communities in any of the countries, in any of the settings. Too often we are tending to use, not least in policy documents, terms like marginalized or difficult to reach, and they are discriminatory terms, and they are condescending terms. I think we need to take a lesson from a number of the presentations we've heard, and in particular from the difficult Arab situation in Israel, where we value the communities and we come to it from their viewpoint. I have for the last 10 years been inspired in a lot of my work by a couple of papers by Christopher Schoell, which is, we design systems for people like us. In other words, educated, middle class or better, citizens of our own country. And if we do that, then anybody who is from a different culture or chooses a significantly different lifestyle, let alone those transferring in a hurry for economic or refuge reasons, we don't think like them, not least because we haven't talked to them, we haven't understood them. And I think it is inherent on us as health professionals and human beings to get inside the thinking, the society, and the anxieties of those people we're trying to reach, and to move away from saying they're difficult to reach or they're marginalized, and saying we as good hosts have a duty to make them feel valued, welcomed, and understood. And I think the underlying key messages from so many of the presentations this afternoon actually have had those values. Maybe haven't had the strength of putting it that way, but I think those values are important. So we start with translation. Is the literature in a language you can understand? Right through to how do you want services organizing? What will be best for you? And that is clearly what is happening in Israel. But when we come to some of the other groups, then that's much more difficult, either because they are in temporary accommodation or poor accommodation, or find difficult physically to access the services we provide for our majority populations, either because of charges and getting insurance cover, or because of getting to where the centres or the immunizations are undertaken. So it is a challenge to us all, I think, to say, are we really building bridges, but are we travelling over those bridges into the other community, rather than say, we built you a bridge, now you come to us. So that's a challenge for me in many things, and it's what I've heard today is the encouragement that many people are starting to think of those bridges, what travels over those bridges, and how we really get inside the thinking of the communities we have tended to call difficult to access. And picking up the themes of Sir Michael Marmot and societal causes of ill health and inequality, health inequalities. The concept of positive universalism is not that we are treating these children of these communities specially in the wrong sense, but we are saying if it isn't as easy for them to have universal access, it is incumbent, it is a duty on us to give that extra effort to give them access. And I think we've heard a lot of that today, and I'm very encouraged. What I have learned, and it's a very interesting one, and I always love learning from chairing sessions, is the issue about mandatory vaccines, or vaccines being compulsory. Because most of the literature says it appears to be a bad idea. It produces a resistance to health services, and particularly to preventive health services. But then we've heard the very good example in a particular community with a particular culture, which is to say, no, we take that as an indication of trust. You would only make it mandatory if it really, really mattered. So it's not a conformance issue, do what we tell you. It is an offer issue. It's got to be really good for us to say it's this important for you. And so it's a value statement, not a compliance statement. So even on that issue, I think what I've learned this afternoon is we don't take a stock answer. We take an answer that says, now, why do we want to make it compulsory? And how do we make it compulsory? Or so easy to access that you look unusual if you don't take up the offer on behalf of your child. So I think that again comes back to the issue of values, of understanding the societies we serve, and to working to recognize, respect, and work within those values. I know you're going to cut me off on time, Daniela, being a good chair, so I've just got two quick other thoughts. One is the continual challenge of record keeping. A number of presenters have mentioned this, and not least it's difficult in refugee or rapid movement situations, but getting good records, avoiding duplication, enabling people, particularly as they move, to take the record with them and not have to recreate it or double immunize the child. So record keeping is incredibly important. WHO recommends parent-held or child-held records. Home-based records is the official term. And the second thing, and I haven't got my own thinking straight, is where we have people living in a community where we hope their stay is temporary, and that obviously applies to many of our Ukrainian visitors. It may apply to others as well. To what degree do we make their children conform to our immunization schedule, which means a catch-up and a variation? And I'm hearing that in my own country where I live in Ireland, oh, we have to get all the children up to our immunization schedule, without any thought about what happens when they go back and they're out of harmony with the Ukrainian immunization schedule. But whether we say, oh, you live in a little Ukrainian health community is a very different story. Like you say the same for other conflict migrants as well. So I'm not being particular to Ukraine, it's a very good example. And my concluding thought on that, we say to people, if you are in a strange country, come in a hurry, very insecure, then one thing that's good for you is to eat your own food as much as you can. It makes you feel settled, secure. Food is a huge comfort. So we welcome Ukrainian kitchens and the like. But then when it's something like immunization or the way other healthcare is delivered, oh, because you're staying with us, you do what we think is good. And surely health is on a standing, if not greater than, food. And sometimes we say, we do what's comfortable for you, as long as it's also safe. And that's a huge challenge, and I haven't got an answer. But Daniela, I hope you're not expecting answers from me. But stimulation to the thinking that's going on, I leave that thought with you. But a wonderful session and some excellent, all excellent presentations. So thank you to all the presenters. Daniela, yes. Back to you.
Yes, thank you very much, Michael. And I fully agree that we had some wonderful and rich presentations, but your words make the presentations and the relevance of RiverEU even better and more. So I'm very happy and proud that we have you on board. And I think you have raised some very important questions. So thank you for that. And thanks again to all the researchers that presented today. And well, as you have heard, they are all very driven and passionate researchers with a heart for underserved communities in society. My introduction was a little bit chaotic and I forgot to introduce myself, but that's minor important. But I don't want to forget Hanneke Vervoort, who helped me as always, but now in the questions and answers round. But I also would like to mention Michael Edelstein, who is the co-PI of RiverEU and also very important. So now it's time to end this webinar. I again thanks to the presenters, but also thanks for the audience and their questions. And I'm wishing you a nice rest of the day and hope we meet again. Bye-bye.
Bye-bye.